From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Good evening, folks. This evening I want to talk a few minutes about male sexual dysfunction. Please visit our website at www.drpaul.org for more videos on this subject. But I want to talk about how to diagnose this problem and what you can do to help the patient with a sexual dysfunction. First of all, the history is very, very important. And initiating the history is very important because most people do not feel comfortable to bring up the subject. I mean, they will have sexual dysfunction in their life, but they do not feel comfortable to talk about it. They feel embarrassed. So it's doctor's responsibility to bring it up and to explore the problem and to diagnose the root cause of the problem and to treat the problem. So this is a complex issue that you need to bring it up. So a physician should initiate the topic of sex, and so he should initiate or she should initiate and to discuss their potential issues. And a complete medical and sexual history should be obtained in an effort to assess whether the cause of ED is organic or psychogenic or multifactorial. So what is the cause? Is it an organic cause, psychogenic cause, multifactorial cause? And is it coming from any hormonal deficiency? Is it coming from changed circumstance of the patient? Is it coming from stress or anxiety at the job? Is it coming from a condition like polycystic ovarian syndrome? So you see, there are so many different things. So you need to take a complete sexual history of the patient and his or her partner, and then you need to talk about things like premature ejaculation, any lifestyle factors such as sexual orientation, and patient's distress from ED, performance anxiety, and details of sexual techniques they are using. And you can actually talk, and people feel comfortable talking because you are addressing their problem. And there are scales like International Index of Erectile Function, IIEF, International Index of Erectile Function. There is SHM, Sexual Health Inventory for men. So SHIM. So IIEF and SHIM. These are the two scales you can use, and they are available on internet for a Google search in a few seconds. And you ask about medical history, sexual history, psychological history, and the history should note whether the patient has experienced any trauma. Pelvic trauma can cause sexual dysfunction. Any radiation to pelvis can cause sexual dysfunction. And any urinary tract symptoms and repeated urinary tract infections can cause sexual dysfunction. And any bladder outlet obstruction. And also you should focus on the symptoms. How did the symptoms start? What is the duration of these symptoms? Do you get erections? And how strong are the erections? Are they partial or full? Now, how do you distinguish between physiological erectile dysfunction and psychogenic erectile dysfunction? You should ask about nocturnal erections or early morning erections. Nocturnal or early morning erections, they help you to distinguish between physiological erectile dysfunction and psychogenic erectile dysfunction. Let's say ED. So nocturnal erections occur during REM, that is rapid eye movement sleep, and they require intact neurological and circulatory symptoms. So organic causes of ED are characterized by a gradual and persistent changes in rigidity or the inability to sustain nocturnal, coital or self-sustained erections. So you see, if the patient is having nocturnal erections or early morning erections, that means the problem is more psychogenic. If the ED is happening gradually, probably the patient is having more physiological ED because it is developing over the time. So you also think about any endocrine abnormalities because increased prolactin or decreased testosterone can cause erectile dysfunction. And it is useful to ask whether the problem is confined to coitus with one partner or different partners, because if ED happens with only one partner, not happening with other partners, that means it is psychological. And so you say, just by asking these questions, you can come up with the root cause of the erectile dysfunction the patient is having. So situational ED, like in this situation is happening, in this situation is not happening. So situational ED is psychogenic ED. So by asking a few questions, are you having erections in the night, in the early morning? Are you having with one partner, not having the other partner? So those are the questions that lead you to physiological ED. Then there is other causes like coronary artery disease, diabetes. They can also cause surgical history. Why? Because surgeries like done on bladder or prostate, they can actually injure the nerve supply and cause erectile dysfunction. So medical history is important, psychological history is important, surgical history is important, social history is important. You need to ask about any divorce or financial concerns, any anxiety, any stress in the patient's life. So all these different parts of history will help you to find the root cause of this problem. And many times people who have coronary artery disease probably on their way to develop physiological ED, because you see the penis is supplied by a lot of blood vessels, and when there is a coronary artery disease, the heart blood vessels are affected. So the patient has propensity to develop vascular disease. So if he has vascular disease in his brain and has a stroke, if he has vascular disease in his heart and has a heart attack or myocardial infarction, if he has a vascular disease in his kidney and has some renal problem, then patient is on his way to develop ED most probably. So you need to keep an eye and encourage patient to understand the problem. After the history, you need to do physical exam, like the anatomy lesson, corpus cavernosum, corpus spongiosum, and is there any reduced testicular size, and does the patient have any loss of secondary sexual characteristics like hypogonadism. So look for those signs, look for any neurological dysfunction, and see whether the tone of anal sphincter, for example, that helps you. Bulbocavernosus reflex, that helps you to find out any neurological problem. Now, a word about bulbocavernous reflex is it is useful for testing spinal shock and gaining information about the state of spinal cord injuries. If a patient has spinal cord injuries, you need to test for bulbocavernous reflex. Basically, you see the anal sphincter contraction in response to squeeze in the glans penis. So you squeeze the glans penis and you measure the anal sphincter contraction, and if the nervous pathway is intact, there will be anal contraction. If it's not, that tells you some of the spinal nerves are damaged. So right away, by that one test, bulbocavernous reflex, they actually diagnosed the patient's cause for erectile dysfunction. So you see, folks, there are so many things you can do just from history and physical exam. Then you go for the labs. You measure serum testosterone, because low testosterone causes erectile dysfunction. You test them for prolactin, because high prolactin, hyperprolactinemia can cause erectile dysfunction. And then you correlate those findings with the patient's physical examination. So these are the most important things. And there are other things like you do CBC, lipid profile, because hypercholesterolemia, hyperlipidemia is a risk factor for ED in the long run. And anemia, patient could be fatiguing too early, not able to perform. Diabetes, another risk factor for erectile dysfunction. Because in those blood vessels, the plaques will form quickly and reduce the blood supply to the penis. And the other thing is PSA. any prostate problem is happening here. I mean, you don't have to do PSA in every patient who is coming from with ED, but when you do a digital rectal exam and find out that the patient has some benign prostatic hypertrophy or something else, like any serious signs for prostatic cancer, then you need to do a PSA test also. And there are other testings based on patients' need, like nocturnal penile tumescence and vascular testing, injection of vasoactive substances. You can do penile Doppler ultrasound, penile angiography, and dynamic intrusion cavernosography, nocturnal testing. So all these tests, you don't have to order on every patient, but whenever you feel that the patient's clinical condition warrant these tests, you need to order those tests and find out what exactly is the cause. Now let us talk about treatment. The patient education is very important. You need to educate the patient and his partner, and you need to give goal-directed therapy. And you need to take the full spectrum of the patient when you plan the treatment process. And you need to discuss the treatment options, how the treatment best offered and stratify the first line, second line, third line treatments. And patients who are at high-risk lifestyles like obesity, you need to encourage them to lose weight. Smoking, stop smoking. Use a nicotine patch. Using drugs, tell them to stop drugs, because smoking, alcohol, obesity, all can cause sexual dysfunction. And therapies currently employed for the treatment of ED, they have like oral phosphodiesterase type 5 inhibitor therapy, that is the most commonly used. All of you might have heard about Viagra. There is injection therapies, there is testosterone therapy, there are penile devices, and there are psychological therapy. So remember those things. Oral phosphodiesterase type 5 inhibitor therapy, that is the most commonly used. And there is injection therapies, there is testosterone therapy, there is penile devices, and finally psychological therapy. In addition to what we have suggested, you should think about any comorbidities. As I said, obesity, encourage weight loss. Smoking, encourage smoking cessation. Let's talk about oral agents. There are three: sildenafil, tadalafil, vardenafil. So those are STV, like STD, STV, sildenafil, tadalafil, and vardenafil. They are the only approved and they are the only effective oral agents for the treatment of ED. And they are helping so many people. I have a patient coming with and wondering what's wrong with his partner, and she was irritable and moody and looking depressed all the time, and she's perky. And I gave the patient some Viagra, and after a week he came back and said that everything is going wonderful. After a month he said like everything came back to normal, and his wife is so happy now. So you see that one pill changed the relationship forever. Viagra. So oral phosphodiesterase 5 inhibitors are revolutionizing the treatment of erectile dysfunction. So this should be offered to patients who qualify. They help a wide variety of patients. Even psychogenic ED people will get relief with Viagra. Even some surgery, like after surgery, patient has ED, even those patients will develop the response. The onset of action is like 60 to 120 minutes depending on the medication used and other factors such as any food intake, and any reduced initial dosage should be considered for patients who are elderly or taking concomitant alpha inhibitors and have renal insufficiency, because they can cause hypotension. And there are other medications like which act on CYP3/4A enzymes like cimetidine, ketoconazole, and etraconazole. What they do is they increase the serum concentration of phosphodiesterase 5 inhibitors, and they promote hypotension. Hypotension, that's the one word you need to remember always when you're giving these medications to people. hypotension. Dangerous hypotension can come to these patients. So whenever you are prescribing these medications, remember that and always educate the patient about that potential and serious complication or the side effect of this medication. So we have seen this, and there are other side effects like abnormal vision attributed to Viagra, for example, because of the phosphodiesterase 5 inhibition in the retina. So they may have abnormal vision, but thankfully it's only short-lived. And there are more serious problems that this can cause. There is a non-arteritic anterior ischemic optic neuropathy. Remember that. This medication can cause non-arteritic anterior ischemic optic neuropathy. That's a side effect that can be caused by Viagra. So whenever there is visual problems, you should always tell the patient to inform you about that. And you need to evaluate that problem. The optic neuropathy can happen with these problems. So first of all, when you start this patient, give a full session of patient education. That's very, very important. And then you need to follow the patient closely, how this medication is helping them. And if it's not helping, just don't keep giving that medication. Try other therapies. There is a testosterone therapy, there is penile injections, there is surgery, there is intrapenile devices, there is also sexual therapy. So you can actually go through all this wide range of treatment options when dealing with erectile dysfunction. Now, let me finish by saying a few important things about side effects. There is one thing called blue halo effects. Blue halo effect in patients with the sildenafil, they can have this transient altered colored vision. That's called blue halo effect. And also patients taking tadalafil can have loin pain. So blue halo effect, loin pain, hypotension, altered vision. So those are the words you need to remember when you talk about the side effects of oral phosphodiesterase 5 inhibitors. And they are contraindicated in some patients. Who are they? Cardiovascular disease. I mean, if the patient has serious cardiovascular condition, and if you produce hypotension, they may go into shock. So you don't want to give these pills to somebody who has a serious heart problem. And also, sexual activity is a strenuous physical activity. You are not going to give these pills to a person with a severe heart disease and jeopardize his health by giving these pills. So the patient's clinical status is very, very important. Is the patient can tolerate the activity from this medication. If the patient has hypotension, hypovolemia, don't give this, because hypotension, hypovolemia, they become only worse with Viagra. So that's a very important point. And tadalafil, it has longer half-life compared to others. But the basic point is, you need to see the age of the patient, his past medical history, and then based on that, you need to think about pharmacokinetics and pharmacodynamics of these patient medications. And there are other treatments like androgen therapy, like testosterone. Let me say a few words about testosterone replacement. Testosterone replacement is good when the patient has hypogonadism. And when the patient has low testosterone, give it. If the testosterone is normal, don't give it because it is useless. So if the patient has low testosterone, give it. You can give it a gel, you can give it a transdermal patch. So there is oral preparations also now coming. So men who have testosterone therapy, give it and follow them closely, like every 1 to 3 months, and assess how it is helping them. And always look for side effects of testosterone like gynecomastia, sleep apnea, development or exacerbation of lower urinary tract symptoms. And testosterone also causes benign prostatic hyperplasia. It can also cause prostate cancer. It can decrease HDL and put the patient at risk for heart problems. It can raise LFTs and cause hepatitis, and it can decrease fertility. So what are you looking at? Testosterone has side effects, and you need to follow the patient closely. And you can order a PSA down the road if the patient has some prostatic hypertrophy, because testosterone causes prostatic hypertrophy. And then think of other treatments like intracavernosal self-injection, penile prosthesis, and sex therapy, and other stuff. So let me recap and I will finish. Male sexual dysfunction. If your patient comes to you, just don't throw some Viagra at him. Explore history, medical, psychological, surgical, social. Take all that history and do physical exam, bulbocavernous reflex, any signs of hypogonadism, any signs of loss of secondary sexual characteristics, and go for the labs. Check their testosterone, prolactin, and check their cholesterol, check their CBC. And based on the patient's condition, you can go for other testing like nocturnal penile tunescence and ultrasound of the penile vessels. And finally, treatment. Consider the treatment based on the patient's history and physical exam and labs. Is the patient good for oral phosphodiesterase 5 inhibitor? Is it good for testosterone? Is it good for sexual therapy involving a psychologist? Is it good for surgery? Is it good for some cavernous injections? So you tailor the therapy based on the patient's condition. So that's about male erectile dysfunction, and I hope you got something from this. Thank you very much.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.